All right, guys. So glad to be back up front. I'm going to talk a little bit about some of the research that we do here at Hopkins, because this is really kind of the twin arm. There's the clinical efforts, which you've heard a lot about today, but we're also doing a lot of work behind the scenes to try and answer new questions in hypertrophic cardiomyopathy. So really a lot of this is based on, we've developed the Hopkins HCM Research Registry. This is a database where we track the kind of clinical profiles and the disease courses of HCM patients that we see here at Johns Hopkins. This is what it looks like on the back end. It's an online database powered by something called REDCap. When we see a patient, we enter all the information, echocardiogram, MRI, kind of when they came to see us, what they looked like when they came to see us, how many symptoms they were having. And for each of those different things, we enter all the details of that echocardiogram. So how thick was the wall, how significant was the gradient, things like that. And at this point, we have more than 1,200 patients that have been seen at Hopkins and are enrolled in this database. And it really lets us answer a lot of questions that we wouldn't be able to answer otherwise. So this is really a powerful tool for trying to A, come up with new questions, and B, try and figure out the answers to those. And this is all done in kind of protecting your healthcare information, so it's de-identified, protected within the Hopkins firewall, so you don't need to worry about that side of things. Just present a kind of a potpourri of some of the research problems that we've been working on over the last couple of years. So this is not an exhaustive presentation. You've got some abstracts of our work in your folders. Talk about a couple of these projects. So first one is looking at atrial fibrillation in patients with hypertrophic cardiomyopathy. So as Dr. Barth mentioned, atrial fibrillation is an abnormal rhythm that comes from the top chambers of the heart. And this puts people, A, at risk for symptoms. People can be very short of breath when they have atrial fibrillation, but also at risk for stroke. And so people with HCM are at higher risk than the general population for developing atrial fibrillation, and they develop it at a younger age, but not all patients are at the same level of increased risk. And one of the questions that we tried to answer is who should be monitored more closely over time so that we catch atrial fibrillation earlier and prevent that stroke by putting somebody on a blood thinner. So this is work that we started in collaboration with the group up at Leahy in Boston, put together a prediction score, the HCM AFib score, takes readily available clinical variables like people's age, how long they've had hypertrophic cardiomyopathy, some of the echo findings like how big their atrium are on that echocardiogram and whether or not they have symptoms, plugs it all into a math equation and gets us a prediction for how likely that patient is or is not to develop atrial fibrillation over the next couple of years. And really we found that this was quite effective. So people can be very accurately split into low risk, medium risk, or high risk for developing this sort of arrhythmia. And we use this to kind of guide who should have a heart rhythm monitor every year versus every couple of years. And we first looked at this in the group up in Boston and then have validated this in the Toronto HCM Center, and it really seems to hold up under scrutiny in different populations. The issue, though, is that Boston and Toronto are very white cities. So more than 90% of the patients that were part of that initial development group were white. So we wanted to look at our population here in Baltimore, which reflects the city that we live in, with much higher diversity than some of these other places. So we looked at this in a cohort of patients, people in this room, who had hypertrophic cardiomyopathy, and we looked at whether or not they developed atrial fibrillation over time, and we found that, again, this HCM-AF score that we developed really works well, regardless of age, race, ethnicity, for predicting risk for atrial fibrillation going forward. And as a result of this was actually incorporated into the recent set of AHA-ACC guidelines for management of HCM, which we're really proud of, got a Class 1 indication for helping to guide some of the monitoring for folks with atrial fibrillation risk. Another project that we've been working on, everybody's talking about artificial intelligence. We've dipped our toes in this as well. Mostly using electrocardiograms or ECGs. Dr. Barth talked about this as well, but the guidelines recommend consideration of ICD in patients who have high-risk features. So that's things like family history, passing out, things on your MRI like scar tissue or apical aneurysm or really, really thick hearts. All of these things kind of put you in that box of higher risk for sudden death. And a lot of the time we need an MRI to figure out whether somebody has one of those high-risk features or not. But the problem is that not everybody has availability of these MRIs. So not everybody is able to come to Hopkins, and people who are in different countries may not have as easy access to these advanced imaging resources. So one of the things that we wanted to do is to figure out, is there a way that we can use the testing that is available, things like ECGs, to figure out who are the patients that are going to benefit most from getting to an MRI. And what we did is we developed some AI tools that used ECG data directly to figure out who's going to have one of these high-risk features or not, and kind of guide them in a more targeted way towards advanced imaging. So it takes an ECG, raw ECG data, plugs it into one of these models, and gives us a prediction for presence or absence of any of these high-risk features that you would see on an MRI. This again was in collaboration with the Leahy Group up in Boston. And when we looked at all of the patients that they had up there who had MRI, about 10% of those patients were high risk. They had one of these red flag features. And we tested kind of alternative screening programs for these patients, hypothetically. So if you did an MRI in everybody, you would catch all of these high-risk features. You'd have 100% sensitivity for high risk, but you'd also be doing unnecessary MRI in 9 out of 10 patients. You're kind of over-screening everybody. If you did MRI in nobody, you'd only catch about half of those high-risk features. You'd miss a lot of people who are at high risk for sudden death, but you're not going to be wasting any MRIs on people that don't need it. And so then, the proposed thing that we came up with here is, what if we just did MRIs in the patients that the AI algorithm had recommended getting an MRI? And what we found was that we can still catch 97% of the people with high-risk features while reducing the total number of MRIs that we need to do by about 60%. So again, we're not proposing that we replace MRI or anything like that. This is a way to help guide a limited resource, particularly in places like developing countries, things like that, to more adequately funnel the resources to the people that need them. And that's what we did. We looked at patients in India and found that these models really worked pretty well. Again, this is all kind of hypothetical at this point. We've got our models generated but not clinically rolled out. That's something that we're thinking about doing for the future. Another thing that we've been looking at, LV apical aneurysms in hypertrophic cardiomyopathy. You guys have seen this picture already. Basically, aneurysms are these outpouchings in the tip of the heart, that tip of the football, which are a lot of scar formation and put people at risk for both blood clots and stroke because blood pools there in the tip of the heart, and for sudden death. So really an important finding to identify, particularly identifying early so they can get the treatment that they need. Usually these are identified either with cardiac MRI or with a special type of echocardiogram where we use contrast to see that tip of the heart much better. And if we do see one of these aneurysms, we treat people with defibrillators or with blood thinners to kind of reduce those risks for really kind of serious negative outcomes. So here is a patient, regular echocardiogram, base of the heart is at the bottom, tip of the heart is up at the top, and it's kind of hard to see what's going on is the problem. And the truth is that these aneurysms are really missed quite often on run-of-the-mill standard echocardiography. And we have to use these advanced techniques like using contrast to enhance the MRI to find that aneurysm. So we wanted to see, are there ways that we can are tools at our disposal to better identify people who need, again, these advanced imaging techniques like echo contrast or cardiac MRI. And when we looked at our HCM research registry, we saw that there were more than 50 patients that we see here at Hopkins. Not a lot of patients, but enough to start looking at as part of a research effort. 50 patients with LV apical aneurysm. And we wanted to see if we could improve the performance of standard echocardiography to diagnose these patients. And what we saw is a lot of these patients had something called the echocardiography finding called early diastolic release flow. It's basically blood, as the heart squeezes, gets forced up into the tip of the heart, and when the heart starts to relax, that blood gets released. And you have forward blood flow at a time when you don't normally see that. And that's a finding that shows up very often on just a run-of-the-mill echocardiogram, but people kind of ignore it because they're not aware of what this is. And when we looked at it in our cohort, again, 50% of the patients that had an echocardiogram, a regular echocardiogram, missed the apical aneurysm. MRI was really pretty good, about 90% detection. Contrast echo was the best at about 100%. And when we looked at just this early diastolic release flow, again, 90% of patients that have an aneurysm had this finding. And so the sensitivity is much better than standard echocardiography. And actually, if you combine the 2D images, that video that I showed you, plus recognition of this early diastolic release flow, you capture just about every single patient with an LV apical aneurysm. So really is a much better way, or having awareness of this improves the sensitivity to detect this high-risk feature compared to regular echo. And we also looked at these patients over time. So a subset of these patients have been followed at Hopkins for 5 years or more, and we looked at how much this aneurysm size changes over time. And we do see a little bit of an increase in the size of the aneurysm over time, 5 to 10 millimeters, and a little bit of a decrease in the heart function over time, 5 to 10%. So kind of reinforcing the fact that we need to monitor these patients closely over time, even after the diagnosis is made. The last thing, and Dr. Madrazo mentioned this a little bit, there's this question of, is risk with LV apical aneurysm the same for all patients, or is it a little bit different depending on the characteristics of the aneurysm? And you can't answer this question with just 50 patients. So one of the other things that this research registry allows us to do is collaborate. So we have part of a study that had 9 different centers throughout the world, India, Italy, UK, a bunch of places throughout the East Coast, and we all pooled our patient data to come up with more than 500 patients with LV apical aneurysm. It's the biggest cohort that's ever been assembled for this. And we were able to look at and answer questions that previously had not been able to be answered. So this is basically looking at risk for yellow is the arrhythmias, and blue is strokes. And as you come from the right to the left, the aneurysm is larger. What we see is that the larger the aneurysm, the bigger the risk for both stroke and for dangerous arrhythmias. And then conversely, the smaller the aneurysm, actually the lower that risk is. And when you get to be a very small aneurysm size, less than 1 centimeter, that risk is actually pretty much the same as for patients without LV apical aneurysm. So this has actually changed what we do in clinic. We're starting to, not black and white. You need an ICD. You need to be on blood thinners if your aneurysm size is very small. So lots more HCM research on the way. Just to kind of mention some of the things that we're talking about. So we've got that exercise study that's going on over there. We're looking at extravascular ICDs, which is a brand new type of defibrillator that Dr. Barth puts in that's a little different, and we're studying how well that performs in patients with hypertrophic cardiomyopathy. We're looking at using some of these ECG artificial intelligence tools to help guide treatment with cardiac myosin inhibitors like mavacamten and aficamten. We're looking for the risk for atrial fibrillation. So there is some suspicion that AFib risk may be slightly increased in people who are on cardiac myosin inhibitors like mavacamten, but that hasn't been studied very well. And then looking into pregnancy and hypertrophic cardiomyopathy. So a lot of different things that are going on. We have a very active research arm. And we're even going to start doing some randomized trials here at Hopkins. It's not been the case for a couple of years now. But we're hoping to bring that to action in 2026. So thank you very much to all the patients in the room, because we couldn't do this research without you guys being here at our center, and then particularly to patients that have supported our research efforts through philanthropic gifts. This is the Leibowitz family. They really have made a fundamental difference in our ability to do these sort of projects. So they are supporting not just the HCM Center, but also a research assistant that we're hoping to bring in to help maintain our database and make research possible. So thanks again, guys, for being here. Thank you very much.